All right. Good morning, everyone. Welcome to another Workshop Wednesday. This week we are joined by Michael Beauregard, who is here to talk about the Canvas to Save Lives program that has been piloted in Providence and hopefully expanding. So without further ado, we'll turn it over to Michael, and we look forward to hearing from you.
Thanks, Jennifer. Hi, everyone. For context, my name is Michael Beauregard. I am the managing principal at Systems Change Strategies, and we are a small consulting firm based in Cranston and all local staff. And we work with nonprofits, public sector entities, as well as we do work with political campaigns. And so the program I'm going to talk to you today is about the Canvas to Save Lives. And the goal in this presentation is really just to share with you about the program and kind of the impetus for why we created it, as well as how, if you are interested in doing something like this or identical to it in your community, what are some of the steps you might be able to take to make that happen. But before I get into it, I do want to just acknowledge that this program is really truly only possible due to the partnerships that have led to its creation. First and foremost, the Department of Health, who really, I think, gave us the impetus to get the idea moving and ultimately pilot it, and funding for that, as well some other great community partners in Providence that we've been lucky to work with. So I'll talk more about them in a little bit, but just rest assured it does take a village to do something like this, and I'll share you kind of some of the key elements that we've identified through our experience of running this program. So just to jump right into it, we do have a bit of a cross-disciplinary team that we've put together to run the program. So we have Dennis Baylor, and so we've been very closely partnered with Project Web Renew. I'm guessing most people on the call are familiar with them, but just for those who aren't, they are a harm reduction organization based in Providence, but also with, I think, presence in Pawtucket and maybe Central Falls. I know that they do work really around the state, and so they are really have been a essential thought partner in this work. And we're really lucky to have Dennis, who is their director of operations, moonlight on our project as our senior canvasser. And so he brings a wealth of knowledge in outreach work and harm reduction training to the program, and we really couldn't do it without him. So really important partner there. As well, on our team at Systems Change, we have Mara Levizow, who is our project manager. She has a master's in social work from Hunter College, and she is really effective in running the operations of the program, or instrumental in running the program. So just want to acknowledge them. And then for context, my background is in advocacy, communications, and political organizing. And so I'll get into that experience in a bit, but that's really, I think, where the idea for the program came out of. So first, I will just provide a little bit of background. Sorry if this is repeating things you've probably heard in other venues, but I just want to make sure we're all on the same page. And so just reiterating the overdose problem in our state and probably in most of your communities. Despite increased attention and focus for the last 5+ years, we're seeing, unfortunately, unprecedented and continually rising rates of overdose in our state. Some 2023 data for the first quarter just came out, but this is the most recent complete year data that we have. And as you can see, overdose fatalities are just continuing to trend up as time goes on. I will just acknowledge, I think there's a lot of good evidence where we'll get into in future slides that this is not necessarily because the efforts that are being taken by overdose prevention groups and people who are trying to prevent overdoses are ineffective, but rather due to the fact that the the drug supply, especially the illicit drug supply, is getting increasingly deadly and toxic. And so I think that's just something important to remember. And you can see, that evidence here in the breakdown of what is showing up in toxicology reports for fatal overdoses. So it's just important to keep in mind most street drugs, opioids or otherwise, are being cut with adulterants like fentanyl, or more recently with things like xylazine, also known as tranq or horse tranquilizer, or nitazene, which is another similar synthetic, I don't know if it's an opioid, but it has similar qualities. As you can see, also those drugs are many times stronger than heroin and significantly increase the chances of an overdose among users who have low or no tolerance for opioids. So more overdoses are occurring among either recreational or completely naive users of drugs, particularly folks who don't think they're taking fentanyl or other adulterants. And so I think it's really important to think about that a lot of the increase is not of overdose is not necessarily hardcore drug users or people who are purposefully seeking these things out. It is in a lot of cases people who are not expecting any sort of opioid or depressant to be in their drugs. They may be taking what they think is Adderall or some other sort of pressed pill that may or may not be legitimate, and then finding that there was fentanyl or xylazine or some other illicit substance that has incredibly strong sedative properties. And so essentially people who are expecting an upper might be getting an incredibly strong downer. And that's really important to know that a lot of people who probably don't think they're at risk are at risk by virtue of what their behavior is doing. So one other big unfortunate trend is that as time has moved on, and I think this aligns with the recreational versus hardcore user divide, which is as time has gone on, more and more overdoses have started to occur in private locations. If you go back to the 2018 or 2017 data, you'll see this split between private and semi-private and public settings much more even. You'll see almost half of overdoses in those early years were in public settings, and I think that's understandable if you think about who were the people first affected by the overdose crisis. It was people who are most vulnerable in our societies: homeless people, who are IV drug users, people who really live on the fringes of society. And so that was where a lot of folks were overdosing, in the streets or in communities, and that's still happening, unfortunately. But a lot more now is happening in private and semi-private locations, where you can see 84% or almost 300 overdoses last year occurred in people's homes or their apartments or garages or campers. So that's quite a huge change in the trends. And I think it's something that we have to be really cognizant of, because traditional street outreach really only gets at the public and maybe some of the semi-private settings. But for the most part, this big 84% of our occurrences, really, unless people are coming into a center or a location, it's very hard to reach these people. So why is it so dangerous? I mean, we kind of touched on that, but just, a few things. One, stigma. If you're using alone or you're using by yourself, you may feel like it is not something you should be doing around others, which, certainly increases the risks, both because if you're isolated, it's something that your family and friends are less likely to know about. But most importantly, if you overdose when using alone in a private setting, the likelihood of that someone is going to happen upon you or be able to see what's happening and call for help is significantly diminished. And so there is just a greater risk of the overdose not just being hospitalization, but being fatal. So really important to note that private locations present a far greater risk to people's lives. And so I'm just going to jump right into why we came up with this idea. Well, we thought it kind of really addresses some of those issues on that prior slide. It's moving upstream, this approach, in how we try to address people. We're not waiting for people to overdose and getting them the help. We're trying to get information and resources to people before they overdose, or at least raise awareness so that they might be more cognizant of how to respond or who to call for help if they are in trouble. So we're focused on private homes. We're really hoping to get more recreational and casual drug users rather than hardcore users who may live on the streets or who may frequent harm reduction agencies or basic services agencies. People who are unaware of harm reduction and safe use practices. This is something we've seen a lot of in our work in Providence. Initially, our program started in just the 02907 health equity zone, so the south side of Providence. And we subsequently have moved statewide, but both in the south side as well as in other regions of the city where there's overdose hotspots or a very high rate of occurrence of overdoses. We have found that people who live next door to overdoses that have occurred or live at locations next door to where an overdose recently occurred will have no idea about Narcan, about the risk of overdose in their community. And so really there is just a lot of information. Like we I'm making some assumptions, but most people in government, I think, have at least heard about the overdose crisis, may be aware of Narcan and some of the strategies the state has taken to minimize overdose in the state. But really, by and large, people across the state of Rhode Island are have not been up to speed on what the latest is. The fact that it's everywhere, fentanyl is being cut into everything, and so that lack of awareness is really what this program hopes to combat. Also, we've noticed that oftentimes the people who answer the door are not necessarily the people we want to be talking to, but they are related. Either they're a family member or that somebody they love is using substances, and so this is another opportunity to talk to those people. And finally, there's definitely, especially in the South Side, but pretty much everywhere we go, which is most overdose hotspots that tend to occur in low-income communities, high rates of renting, and people who are more transient. And so there really is a just lack of understanding, as I previously said, of like what substance use in their neighborhood looks like, and the fact that they could really have a direct impact in preventing loss of life, and really kind of trying to destigmatize the people who are most vulnerable to this. Because as we know, there's a lot of concern about folks overdosing, on people's stoops, on people's blocks. And we found that in talking to people, we are actually able to both educate and change minds and hearts, and get people who previously might be very concerned solely for the fact that the person is proximal to them, to start to care about that person's well-being and actually see their role in helping avert death. So I do think it's something that it's not for everybody. There's certainly people who are very opposed to having Narcan or to helping people who are at risk of an overdose. But I will say there are far more people who are either already open to that, or people who frankly don't know anything, and upon learning more, really want to help. So I just throw those out as all reasons why we attempted the program. And really, what makes canvassing effective versus other forms, it breaks barriers to access by going to people as opposed to either asking them to come to you or getting them online. It reduces stigma because we're doing motivational interviewing and really trying to connect to people's lived experience and having them talk about their stories and experiences with overdose or with drug use. We connect people to services, and we work with the people who do the work. So we employ peer recovery specialists for the program, and they're connected to recovery or harm reduction organizations for the most part. So they have built-in connections within the community to get people connected to help as they identify their needs. And most importantly, it's getting life-saving naloxone into more communities that are at most risk of experiencing overdose. So I'll get into the numbers in a bit, but we have deployed, I think at this point, over 1,000 units of Narcan into overdose hotspot communities. But certainly the numbers I'll show you from last year include over hundreds of units being deployed. So we're really getting Narcan to the blocks and neighborhoods in communities that are most at risk of experiencing overdose. Some key pieces of what has made the program successful, we think, are partnering with our local service organizations. As I mentioned, our project evolved out of the 02907 Health Equity Zone, which was, and particularly their community overdose engagement project, which I think most of the communities on this call have some experience with. So that was backboned by West Elmwood Housing, with partners Amos House and Project Weber Renew, funded by the Rhode Island Department of Health. And now in our statewide implementation managed by the Providence Healthy Communities Office, we still continue to partner with those agencies and really try to work with their staff to be the team that we put out there, so that we're not really trying to step on toes, but also to work with the people who know this work the best. And most importantly, or two other important features, we really are focused on connecting with the communities that are most at risk, which includes, a lot of Spanish speakers. So we make sure to have as many multilingual canvassers as possible. They have to be peer recovery specialists, which in order to be a peer recovery specialist, they need they have to have some lived experience, I believe. And really, this is increasing opportunities in the career field. So it's really just a kind of virtuous relationship we have with these organizations, and we try to be supportive of them in any ways that we can as an organization. And finally, when we talk to people, we seek to empower residents and local leaders that we identify on the doors to help others or help people in their life navigate both overdose, substance use, or even frankly, if they identify a basic needs service that we know there's a service provider in their area, then we'll give them that information. And some of that is included in the materials that we distribute as well. And getting into that, I will, we have a strategic messaging that goes along with this program. So everything in this program has been developed in collaboration with both those organizations that I mentioned, as well as we've made sure to engage with people with lived experience from the Latino community, from the Black community, from the Asian community in Providence, to make sure that what we're providing is within the resources we have as culturally responsive and engaging as possible. So we have our canvassers go out in t-shirts, which declare them as being there doing that work. We have bilingual palm cards that we leave on the doors, which have QR codes linking to the website. There's 3 key pieces of information about Narcan, fentanyl test strips, and engaging with your recovery organizations on the website. There's even more information available in English, Spanish, and Portuguese, as well as if you scroll down a directory of service providers in the area that we're working. So we're really trying to just put all the information and compile it into a simple place where folks can access it and answer any questions that people have as they're out on the doors. We also use a mobile app to streamline and track all of our data. So we have folks go out with what we call turfs that have a clear geographic area that they're going to be going to. Within the system, you can click into households and see individual people who might be at the doors. So you have a sense of who you're trying to talk to when you go to the doors. And then all of the responses are logged in the system and stack up into a analytics dashboard that we track and kind of inform how the program's going. It also allows us to customize the questions we're asking. We have things like we track whether folks receive Narcan or basic services, but we also track people's receptiveness through what we call a connectedness scale, which is a five option Likert scale question, which allows us to kind of assess people's response. And through that question, we've seen a very high level of engagement and interest in learning more about harm reduction. So everything we have done to date has continued to affirm people's desire to learn more and to be an asset or someone who can prevent overdose in their community. Just to give a brief overview, again, I'll share slides. So if you want to read this in more in depth, you're more than will be able to do that. But launching a program like this takes a little bit of time for planning. I will say, I think it's better to give yourself 6 months potentially or more to plan and devise partnerships. I think the most important thing I cannot emphasize enough is having community focused or partner planning meetings with either the social service agencies that you work with in your community or community organizations that you think are key to engaging with your target neighborhoods or communities. So if there are neighborhood associations or there are identity groups or again community organizations that are doing work in your community and have either people able to do this work or have strong connections and understanding of your community, it's really important for them to be involved in the planning process so that the program, if you choose to deploy it, is really tailored to the needs your community is facing. And then there's a lot of logistical things that go into building this up, both getting the collateral ready as well as recruiting and onboarding the team. And then pilot implementation, there's really only, I would say, about 6 months in the year you can do this program in Rhode Island, probably from sometime around March or April, depending on when it warms up, to about September is probably like the widest window. So you really don't want to be sending people out in the middle of the winter. It's not very effective and pretty brutal for the canvassers. So we really focus on the summer and spring months for operation of the program. So these numbers that I'm sharing here are really not inclusive of the most recent citywide program that we're running in Providence, but these are from two, I think at first a month and a half and then 3-month pilots of the program, primarily focused on the 02907 zip code in 2021 and 2022. We'll soon be updating this with the new numbers. I think we've more than doubled these numbers in the last year. But you can see, we attempted over 8,700 doors, had 1,300 positive face-to-face interactions, which is incredibly high. We had a very high contact rate, and I think that speaks to the level of engagement as well as the enthusiasm of our canvassers who are really, talking to people on the street and really just looking for any opportunity to engage with folks. Had 150 plus conversations with folks to talk to the family or friends about it. Again, close to 1,000 kits of Narcan were distributed in those 2 pilots, and a few 12 referrals to service as well. So those are all some of the positive outcomes that came from our first 2 iterations of the pilot. And just getting into what it might look like if you wanted to start this in your community. So suggested first steps include getting that table together of partners and or community leaders who you think would be most interested in running the program. And there's some components that you really want to scope out in putting this together. First, find out what public health data is available for your community. I'll get into that in the next slide, how you can find that information. You want to analyze the local harm reduction and recovery landscape in your community, or if there are not organizations that do that work, then think about who next door or nearby you might be willing to expand or to support a program in your neighborhood or community. Understand the resources that the targeted community might need. So if you anticipate there is going to be housing or food security or social service or staff or TANF benefits that the same people you're going to be going to might want to be made aware of how to access those resources, then I think it's worth thinking, how could you incorporate those into your literature or into the resources that you're making available as you talk to folks. And finally, designing a program for a particular community. I think, I can't say specifically the range of what those things might look like, but there are certainly things within every community in Rhode Island that are unique to it and will come out through those processes. And I think it's really important to make sure to consider that when you're standing something like this up. So just to share a little bit of information about how to kind of just assess the need in your community and potential locations that might be viable for a program like this. So the Rhode Island Department of Health releases data based on EMS and emergency department runs that essentially can pinpoint exactly where fatal and non-fatal overdoses are occurring. And this is the basis for, again, I think most of you have probably seen this, but the map on the left is an overdose hotspot map. And those arrows, which were recently requested by our program, indicate the trends of a given area. So you can see, percentage increases are related to either larger red arrows or decreases, larger green arrows. And so this data is released quarterly. It typically lags the time period for which it's occurring by at least a few months, if not a full quarter. So there is a bit of a lag in the data, but frankly, we have found in operating the program for about 2 years that the geographic locations where hotspots occur tend to remain fairly consistent over time. Certainly there are some that blip up and then kind of disappear, but generally there are going to be in most communities affected by overdose a few locations that consistently experience it, and frankly our experience is they tend to be concentrated in areas with high poverty, high rates of transients, or insecure housing where homeless people tend to congregate. So I think it's really important to identify those places early on and be cognizant of whether that's a temporary thing or that's something that's persistent in your community. But you can view that data by municipality on the Department of Health's Prevent Overdose RI website. Just need to go to the Data Hub tab of that website. And you can, as you can see, break down at quite a granular level, not only location, the time frame, as well as you can see information on both fatal and non-fatal overdoses. So again, I'll share this around, but I highly encourage anybody on this call to take a moment, go to that site, look up your community, and assess whether there are some overdose hotspots, and is there something that your community could be doing to address those specific locations. So that covers my slides, but I would be happy to take any questions now. Also, if folks want to go back to any slides and ask questions about those, I can do that as well. So happy to open up for questions.
Okay, folks, don't be shy. if you can, this is just a meeting, not a webinar, so you're welcome to take yourself off of mute or put your camera on. We'd love to see you if you do have questions. And if not, we certainly can share these slides out as in addition to our recording for today, to anyone else in your organization that might be interested in working on an important project such as this. So I'm going to, I think, leave it there because it doesn't look like we have any questions. But I want to thank you, Michael, for joining us today and for this important work that you're doing. I'd love to follow up with you offline and see how else we can collaborate on this, because I think it's great work that you're doing. So
Thanks,
you.
Jennifer. I really appreciate it.
Yeah.
Oh, sorry,
Oh,
Zulema, were you gonna?
Yeah, I actually had a question. Hi,
Hi.
I'm from Central Falls. I was actually wondering, did anyone from the community have any hesitation about going to their homes and alerting the community about the Narcan? I know you talked about the positive feedback, but I was just wondering what if there was any negative feedback from the
No, that's
community.
a great question. I'm sorry I don't have the connectedness scale question dashboard pulled up, because that's like, it's very telling. By and large, no. I think a vast majority, I would say somewhere in the range of 85 to 90% of people we connect with, incredibly positive. I would say then the remaining 8 to 9% don't want to hear from us. So like, that's kind of like a refuse. There is a very small, like probably 1 to 2% of all people we talk to who are vitriolically, hostile, and we train all of our canvassers go out in pairs, and so that's for safety, but also we just train everybody. If you have a bad feeling, or if you're getting any aggression whatsoever, retreat, don't push the issue, so they all are trained on that. What I will say anecdotally is we did not have any of those circumstances until this most recent go this year, and I can pinpoint it specifically that we, trying to be proactive and in collaboration with the Mayor's Behavioral Health Council, were identified that as the armory was closing in the Cranston Street Armory, that some outreach in that area would be very helpful. And interestingly, it was not the communities. So we tend to focus on the low-income communities just south of the armory. That was not where we encountered the hostility. We encountered it in the rather affluent communities on either side of the park. People one person who was quoted in the press being he says we left Narcan on his doorstep. That is not true. We don't leave Narcan with people we don't talk to. But he was quoted as saying, this is not my problem. And I think that's the most common sentiment, is like, get these people off my stoop. This is not my problem. But to be frank, most people don't think that way. Most people seem to be very appreciative and frankly unaware. So I will say, like, I think there is a small, usually, possibly some of the same people who will be calling you about other issues that you may or may not be able to affect. Those are the people I've found who are most hostile. But by and large, our canvassers have had a really positive response. And again, I don't want that most recent experience to paint. Like, I think it's still a very small percentage of the total people we contact. Most people are just very appreciative to know there is something. And include, we've worked very closely with the Healthy Communities Office in Providence. And one thing, in this new version, we've been very cognizant of is, like, when there are things identified that aren't in our wheelhouse, like directing people to 311, 211, those are resources that exist, but like, frankly, most people are not aware of. So we've tried to be more proactive and, like, not just like, hey, Amos House is down the road, or Project Weber News over there, but like, here are 2 numbers, or 988 if you're, someone experiencing a mental health crisis. So we've been trying to, like, broaden the things we connect people to, because a lot of people don't have an addiction or an overdose issue, but we have information we can provide them that gets them closer to the help they need.
Got it. Thank you so much. I also had another question. Do you happen to know how much it actually costs to run the entire canvassing?
Yes, there is a range. To be honest, the way it has worked thus far is that the Department of Health has said, this is what we have, what can you do? And we've backed into that. So I will say there is a minimum amount of investment to make it worth yours, the canvasser is in our, like, we need time to both set up, to plan and then manage the program. And then we need a certain amount of budget to hire canvassers and just pay them directly. And we do pay based on, like, frankly, the Department of Health has been very supportive or strongly encouraging a high rate of pay for the folks. So we do actually pay all of our canvassers at least $30 an hour, 1099 contractor, which frankly is I think the minimum it would require to recruit the caliber of people that we need for this program. And again, most of them are full-time peer recovery specialists who do this after hours on weekdays and on weekends. So it's not like they're doing and no one's doing more than 15 hours a week, usually closer to 10 hours a week of work. But we do like to have a team of 5 to 6 canvassers. So then, en masse, we have about 50 to 60 hours a week of canvassing hours. Again, so it's very boom bust. Like there will be a month where we double the hours based on our expectations. There will be a month where half the team's away on vacation. And, so we just kind of try to work with people's lives and the fact that they all have full-time jobs. But I can talk more specific numbers. I would be happy to like kind of run through scenarios, but we definitely, like, there's a minimum amount you need to do. And then how aggressive do you want to get? I think for a community like Central Falls, honestly, you could probably run a comprehensive citywide program for the same amount of money. We've been doing a very targeted program in Providence, but maybe that doesn't make sense for y'all. Maybe a more targeted approach initially makes sense. So happy to talk more numbers though offline and kind of put budget scenarios together. But to be honest, we also have the Providence example is not perfect either, because we do have a separate component to that scope of work, which we've been planning and implementing a citywide communications campaign that's focused on not only overdose prevention, but really mental health services at large, which is where that 211-988-311 stuff came together. Like we had time and capacity to really develop a set of communication assets, and also like take all the assets the state and national partners have created. And then we've been essentially like driving a communication schedule, working with all of the social service agencies and community partners to get the message out. So that's like a big chunk of our work with them, so that I would want to take that out in considering the cost of the actual program. But I just throw that out to say there are many different scales to implement this, and I think it's a matter of like identifying who's like the partner agency in your community first, like what is the availability of peer recovery specialists, because it may be that you either need to recruit a community organization or a harm reduction organization to be a partner in doing it in your community, or there's somebody there already who's super game and we can work with them. And I will also just say, we're very much open to not being like to working with a community partner organization, which is effectively running it, and us being more of kind of advisors and consultants. But the way it has operated so far is it's been run through us just because it was pilot, and we kind of wanted to demonstrate that it could work.
Oh, great. Thank you. Yeah, Central Falls didn't really receive a good chunk of the opioid money, the settlement money. We only received 96,000, unfortunately. So we're trying to figure out what would be the best plan for those money. So I just wanted to know like ballpark. So I might get in touch with you offline just to get those numbers.
Yeah, and I think there's a way to make that work. I think the question that just to confirm, that's over the lifetime of the settlement money.
I think we're gonna get another chunk of money, but it's not as of right now. We've got 96,000. I know there's still like one settlement that we only have 2 out of the 18 payments. So I'm not sure how much will each of those payments be, but as of right now, we just have 96,000.
Yeah, and I was sharing with Jennifer before. It has been a little challenging. In that they have deployed this money to the cities and towns, but I think in your case and in most cases outside of Providence, you don't have a dedicated public health focused office, and so this is falling on you as the chief of staff to figure out. So I do think that I'm hopeful the settlement advisory committee has indicated there will be more guidance or technical assistance to municipalities for some of this. So I hope maybe in doing that, they're also able to provide clarity on like the future funding and sustainability, because certainly popping up a bunch of programs with 1-time or 10-year funding and then things going away, these things need to be sustained over year. And so just, being planful about that, because, we just really don't want to help people stand things up and then them not be sustainable. So then you can't have the impact you're looking for. So yeah, happy to talk that through and share whatever knowledge we have as well.
Great, thank you so much.
Thanks, Uli.
Any other questions? Sounds like we're all set.
All right, great. Well, thanks for attending, everyone. Good to see you. And again, Michael, thank you so much. And anything else we can do to get the word out, just let us know.
Thank you. And I will send along the slides a little bit. And then, yeah, feel free, anybody, you have my email. And Jennifer, I would love to touch base and, continue the conversation.
Sounds good. All right. Thanks, everyone. Have a great day.
Thanks, everyone.
Bye.